I'd like to thank David for inviting me to speak here to you all today, and appreciate you coming out. I think this is a great conference. You've got some really heavy hitters in the strength and conditioning world, and you all are very fortunate to have had the opportunity to hear them speak. I'm going to change gears a little bit. I'm a clinician, okay, so I'm not an exercise scientist. This is going to be more of a clinical talk, so I hope I've made it at least relevant to you all. My background is family medicine. So I'm a family physician that went on and did more training in sports medicine as a sports fellowship for a year, and then have practiced both primary care medicine, family medicine, as well as sports medicine. So I've done both. In my role as the medical advisor for the WTA, as David said, that is a very global organization. So we deal with athletes. I'm not just dealing with the US tennis players, I'm dealing with athletes from all over the world who have had different levels of medical care related to where they live, their country. They come with various different thoughts about what's appropriate training, what things they need to take to enhance performance on the supplement side of things, as well as nutrition. They're also different than some of the sports we've heard about, or some of the sports we've heard about today, such as football, which is a team sport. This is an individual sport. These athletes are independent contractors. That means that while the Jaguars pay their players to play for them, and they have a medical staff that evaluates Jaguar players, even though an NFL football player could go outside of their medical team here, right, and their agent may send them somewhere else, our players are independent contractors. The WTA does not pay those players. They're not hired by the WTA. Tournaments pay players based on where they came out in the tournament. If they won the tournament, they get X amount. If they made it to the second round, they get X amount of money, but the tournament pays the players. And so consequently, I'm an advisor. I can give advice, I can make recommendations, and the player can say, thanks, but no thanks, right? We can stop them from playing should they have an illness or disease that could jeopardize their life. So if this is a life-threatening disorder, we could potentially stop that player from playing. The tournament physician is going to do that, as there's a tournament physician at every site throughout the world. So there's different tournament physicians in Beijing, as there is in Hobart, Tasmania, as there is at Wimbledon, which is colors here, significant for Wimbledon. So today, though, that's just a little bit of background of how the WTA works. And we have physiotherapists that are hired by the WTA, and they go to different tournaments. So typically, they'll be at a normal size tournament, let's say Miami, there's going to be about 6 physiotherapists that are there at the beginning of that tournament. As players play and get knocked out of the tournament, then the physios start to drop off, and some of those physios will then go to the next tournament, which is Charleston, South Carolina, and that's where they are right now. So 2 of those physiotherapists will go up there, set up the training room, and then they know those players that have been in Miami, and now the Miami group is coming up to Charleston. But there may be players coming from somewhere else. Maybe not all players from Miami are going to Charleston. Some are going back off to Europe. Maybe some new players are coming in that hadn't played in Miami, and so the physiotherapist may not know what's going on with those players from an injury perspective. Kind of that black hole that Tom talked about earlier with the Jaguars. There's a lot of black holes like that occur on the WTA. So that's just a little bit of background that makes this challenging. And I travel to about 3 tournaments a year. Most of what I do is over the phone. We have an advisor meeting once a week for about an hour, and then I get a lot of emails and a lot of phone calls during the week. And so one of the biggest challenges that we have, and I'm going to talk a little bit more on the medical side, and I think this will kind of open your eyes to a lot of different medical issues that you in exercise science may see along the way, and you say, I don't know what to do with this. You know, where are we going to go with this? I don't have any disclosures, unfortunately. So this is going to be a little more case-based than some of the other talks that we've had. And so this is not a particular player. This is not that player, first of all, in this case. This case is kind of made up of a culmination of a lot of different players that we've dealt with over the years, but I think will illustrate some of the issues that we face in high-level athletes. And I think even though there's a lot of running science that's going to be coming out a little bit later in the presentations, I think there's a lot of overlap here with the case that I'm going to present. So this is a 22-year-old female professional tennis player who presents in May with fatigue. Now, if this was a room of physicians and they had a patient come in with fatigue, half of them would want to head out the back door, okay? Because fatigue is one of the most challenging complaints that we as physicians deal with just with the general population. This is going to be specific to athletes because the reason fatigue is so difficult is the possibilities are huge and endless. And I'll tell you that I don't necessarily have all the answers. It doesn't always work out 100% great. But I think if we get back to basics as we go through the evaluation process, the thinking process, and then what you can do for the athlete, I think you can help probably a good 80-85% of athletes with this. But a lot of people don't get back to the basics. So she has had this fatigue for the last 8 months. Now it's May. So she's been playing tennis now on the Pro Tour for 5 months because that starts around December 28th every year. So this goes back to the previous season. She has a history of upper respiratory infections. She's had about 4 of them in the last 6 months. So that's pretty significant. Of course, it's respiratory viral season too right now. It's flu season, right? We've gone through winter and into spring. She presently has no upper respiratory symptoms, though. She says she sleeps well. She's played every week this year to date without a break. That's interesting. Last year, her ranking improved from 72 to 18. Again, this is a made-up case, but that's a pretty significant increase. And we do see that in some players as they're improving their ranking. In order to improve their ranking, they have to do well, right? They have to play. Now, if you're Serena Williams, you can pick your tournaments, right? Because you're good enough. And when you win Wimbledon or you win the US Open, you get a lot of points. You get a lot of ranking points that really bumps up your ranking quite well. But if you're not Serena Williams, you can't necessarily take a couple weeks off and come back and play and sort of try to peak towards Wimbledon or every quarter as they're trying to get to the Grand Slams where you get the most points. And then she won her first WTA Premier Singles title of her career in that time. So she's really on the up and up here. Her past history, so that's PMH, past medical history. She has a prior history of iron deficiency. She has amenorrhea. I'm not sure if everybody knows what that is, but that's absence of menstrual periods for 3 months consecutively or more. And we'll get into why that's important. She's had 3 prior stress fractures. These are fairly tennis specific, actually. That's why I put them in there. So tarsal navicular, which is in the midfoot, very common stress fracture in tennis players. We usually see a couple of those every year on the pro tennis tour. And that's a bad stress fracture. It goes on to non-union frequently, and so may need surgery to fix that. Not always, but, and then she's had rib stress fractures, not real common in other athletes, right? And the rib stress fracture is usually on the non-dominant side because of the way they pull through with their serve. And then she's had a metacarpal fracture, second metacarpal fracture of her hand. Not real common, non-weight-bearing stress fracture, right? But we're seeing that more and more in tennis. Her past surgical history is negative. Her family history, she had some coronary disease and a grandfather in his 70s, so not necessarily unusual. Medication, she's on oral contraceptives. And she takes some ibuprofen maybe 3 times a day. She's taken that 3 times a day for 3 weeks. And then supplements. She takes a multivitamin, but she quit taking her iron in the past, about a year ago. But she has that history of iron deficiency, so kind of keep that in mind. Her social history, she travels with her coach. She switched to her present coach last year prior to her improved performance. So it's probably good. We'll see. Rarely she sees her family. So, because these girls travel all the time. And then because she's rarely home. She lives in Eastern Europe, but she trains in Florida. So if she was going to take a break, where is she going to take her break? It's going to be here in Florida, most likely, not to go back and see her family. So you question kind of social support and things like that for these athletes that sometimes can be a little isolated. She's taking some university courses online. Her diet, so there is some restriction there, right? So she's avoiding red meat for some reason, and she avoids dairy. Doesn't smoke, doesn't use illicit drugs, and she drinks occasional alcohol. So a review of systems. This is how we kind of think from a clinical point of view. So you have your history of present illness, your past medical history, past surgical history, family history, social history, and now your review of systems. So these are the different systems. So she's got no fever, rashes, no upper respiratory symptoms, cardiac, pulmonary is fine, GI, no issues, genitourinary, no issues, musculoskeletal, she's having some right shoulder pain, which has been attributed to rotator cuff tendinopathy, and that's why she was taking the ibuprofen. More review of systems, and so this is quite important as part of this case. So she has some stress, because she's going to school. She's trying to get a degree, university degree. She's trying to keep up with her classes online. She feels some stress due to improvement in her ranking and expectations. And this is big. We've seen people go all of a sudden. You win a Grand Slam tournament. You've never won that before. All of a sudden, you become #1 in the world. And the stress for that is immense. And some players are just not ready to handle that from a emotional psychology perspective. And then you start to see them deteriorate after that as far as their ranking. She becomes anxious at times, but she hasn't had any real panic attack type symptoms. She doesn't feel sad, suicidal, no lack of interest, but she only feels motivated about 4 out of 7 days a week. Menses, she has her menses monthly, but why is she having her menses monthly? She's on oral contraceptives. There's different ways to use oral contraceptives where you can use them for 3 months at a time continuously, so then you might only have 4 periods. So you have to know how that works as far as what they're taking, how they're taking it. And she started the oral contraceptives when she had the amenorrhea, and she has had that amenorrhea or absence of periods for up to 3 months at a time, up to 3 to 6 months at a time, and she's had that multiple times since she started her menses, which is around 15 years of age. It's a little on the late side, but it's not abnormal. Physical exam is essentially normal, although she's a thin-appearing female. So just to get some audience participation and try to keep you awake after lunch, anybody have any thoughts? What are you concerned about from that history? The exam was pretty normal, except for a thin appearance. Yes, ma'am. Her stress, yeah. Right. So she's played a lot, right? At least in the last 5 months, she hasn't taken any time off. We didn't really get into maybe last season either. So one of the things, the off season for the professional tennis stars is very, very limited. So they usually end about the beginning of November. And then, like I said, Typically, they start the end of December as far as competition for the WTA and ATP Tour. There may be some International Tennis Federation or ITF tournaments into November. And some of these players that are not ranked that high are still playing some of those well into November. And then, so they have to start training again to get in shape to play December 28th. So it's a pretty short off season. Yes. Quality of sleep. Yep. We'll get into that. Anything else? Right. So she was iron deficient in the past, but she's not been taking iron in a while. Okay. Anybody concerned about her history of amenorrhea and stress fractures? Does that make anybody think about a specific condition? Female triad, right, right. So we'll talk about that a little bit too. Very good. Okay, so this is, I put down my concerns. So one of them was the iron deficiency. So she's got that history, but she's been off. The amenorrhea. So one of our issues is with the amenorrhea and the female athlete triad, which we'll talk about, is do we know if, can we use her periods as a sign that she doesn't have female athlete triad right now? No, we can't, right? You're shaking your head. No, and that's because she's on oral contraceptives. So they're going to make her have a period. So we don't know if we can't use that as our thermometer or gauge to know if her periods are truly normal off the pill. So she still could have female athlete triad. She's been playing a lot without any breaks. That was mentioned. So is that adequate recovery or not? So when you think about, there's training, and then there's also overplaying. So you could overtrain, and as part of that overtraining, it could be overplaying in this case. And it depends how deep you go in a tournament, right? If you lose in the first round every time, well, then you've got the rest of the week to train and take some breaks and recover. If you go deep through the tournament, and you keep doing that, you're going to be playing an awful lot, and you're trying to train during that time and make adjustments in your training to be able to tolerate that. I mean, we just saw, if anybody follows tennis, Sloane Stephens just won the Miami tournament. And then she cited exhaustion, mental and physical exhaustion, as a reason she pulled out of Charleston. So she withdrew from that next tournament because she'd played a lot, and I think she did pretty good in the tournament previous to that. So, and then the stressors. We talked about stressors. So what stressors does she have? Her expectations with her improved ranking. What are the expectations of herself? What expectations does her coach have? Her parents? Junior tennis is expensive to have kids go around their country, their region of the world, pay for all those lessons, all those coaches. I mean, sometimes sport is expensive. And so what do the parents feel about that? They put a lot of money to helping her career get off the ground. What are the expectations of her sponsors? And now she has new obligations because her rankings improved. She's won some big tournaments. And then she has a new coach. What are their training ideas? What are their ideas with recovery? And general relationship with the player. Is it a toxic relationship or is it a good relationship? And even though she's improved, sometimes improvements occur even with toxic relationships, but then eventually they hit the cliff and they fall off. And she's taking university classes. So she's playing professional tennis, which is a significant demand, but now she's also trying to keep up with classes. As your athletes do too, they're supposed to, right? So on the WTA, when we start to hear about fatigue, we have developed, and this is mainly through our psychologists that developed this well before I got involved. And so we have a performance fatigue questionnaire, and we look at, particularly we're dealing with female athletes, obviously, and so menses are very important and can be a gauge towards the female athlete triad as long as they're not on hormones. But you don't want to know just amenorrhea now. So she's had, let's say somebody comes in and they've had amenorrhea for 3 months or 4 months. Well, what's happened in the past? Has this been an off and on thing, or is this just a one-time thing that's occurred? And then training diary. So we ask them about volume of play and practice. We're looking at ranking. Have they improved their ranking significantly like this? And then other training. What are they doing outside of playing? So, and then are they taking breaks? Because we know if they just continue to play and they're going, they're going into the second round commonly or third round at each tournament and occasionally winning, that's a lot of tennis. And then what kind of recovery techniques do they use? What kind of social support do they have? Who travels with them? Sometimes even the parent-player relationship is not great. Sometimes coaches are parents also. So there are players whose parents are coaching them. And I've seen some players break down talking about that relationship, wanting more of a parent than a coach at times. And that's a hard thing. What about nutrition? And so we're lucky enough we have a sports nutritionist, that 2 of them that work with us and these players. And so it's all part of it. So the 3 of us, the psychologist, myself, and the nutritionist, oftentimes are working towards trying to help players as a team. And then again, their psychosocial history, and it's a very multidisciplinary approach, as I'm talking about here. We have a medical advisor who's an orthopedic surgeon, plus the rest of the group that I talked about. So this is kind of the differential diagnosis, and this is not everything. And that's why fatigue is so challenging. We don't want to assume that it's just due to the psychological reasons. We want to make sure that we've ruled out other issues, such as thyroid disease. Adrenal insufficiency is pretty rare, although there's all these adrenal support things out there. I would be very cautious with that. And there was an actual recent study from Mayo Clinic up in Rochester where they took the 12 most popular ones online, and they found that there was thyroid hormone in those, as well as various corticosteroids, so which are on the banned list, by the way. So. But infections, mononucleosis being big in this group. And I've seen some players who it was a delayed diagnosis where we came up with mono, and sometimes they try to come back too soon, and that fatigues them for the rest of that year. A lot of our players try to come back too soon. They want to play. They want to get back out there. Rheumatologic, rare, but it can happen. Cardiopulmonary disease, again, rare, except for exercise-induced asthma. She did not have any pulmonary symptoms, so we'll say that's probably not the cause. Electrolyte disturbance, relatively rare. Nutrition, iron deficiency, this is big, the nutritional deficiencies, and then disordered eating, just not getting enough calories. And then the psychiatric aspect, anxiety, depression, and sleep disorder. We'll talk a little bit more about that. And then the female athlete triad, and last but not least, of course, is overtraining syndrome. And most of our athletes are not going to get to that point in time. So we'll talk about a few of these things. We can't talk about this whole list. Iron is necessary for synthesis of hemoglobin. We all know that. Hemoglobin is going to be to help us with our oxygen carrying capacity. But iron is also necessary for other enzymes and helps within the Krebs cycle. Deficiency can affect performance, particularly in anemia. It's been very well established with iron deficiency anemia. When you truly develop an anemia, so your hemoglobin is low, you don't have the same oxygen carrying capacity, that is going to cause decrements in performance, particularly in the endurance aspect. Iron deficiency without anemia may also cause some decrements in performance too, in endurance. Improving iron deficiency without anemia can improve mood, which can also help with respect to fatigue, and in some cases endurance when compared to placebo. So with iron deficiency, we have to look at how do we diagnose iron deficiency, and I know Dr. Hooper is going to talk a little bit about this in the future, but ferritin is an acute phase reactant. So we have ferritin is our storage iron. And so that is oftentimes the main thing we're using clinically to diagnose iron deficiency. You can get a total serum iron and TIBC are helpful, but they're not great when it comes to truly diagnosing iron deficiency. But you have to remember that ferritin, that storage iron, also is an acute phase reaction. So if you have a lot of inflammation in the body, let's say you have mononucleosis, your ferritin may be falsely elevated. And so you may think that they have iron deficiency or that they don't have iron deficiency when in fact your ferritin is not a good gauge at that point in time. Hepcidin is a protein made by the liver. It tends to help control iron as far as its export into the macrophage, from the macrophages and liver and intestinal cells. And so with inflammation, hepcidin rises. And actually, hepcidin increases after exercise. So if you have an intense bout of exercise, you're going to get an inflammatory response due to some of the cytochromes, interleukin-6 being one of them, which may increase your hepcidin levels too. So if you get into problems, you can't tell if that ferritin is an issue or not, you can order one of these other two tests. The soluble transferrin receptor is a test that is clinically available, although not in a lot of labs. It's extremely expensive. But it is something you could do that is not affected by inflammation. So, but probably 90% of the time we're going to use the ferritin level as our gauge for iron deficiency. So this is how you determine what stages of iron deficiency you have. So you've got the normal category, the non-anemic iron deficiency. So anemia has not occurred. So you have normal hemoglobin, hematocrit, red cells. MCV is mean corpuscular volume, and MCH is mean corpuscular hemoglobin. They're normal, but the ferritin's low. And in general, less than 15 is what's considered a low ferritin for most of the population. It varies a little bit lab by lab. For the athlete, some would say less than 30. And so there's a case that if you're an elite athlete, that above 30 is probably the goal for you. And then in iron deficiency, then you're going to start to affect the red cell size. So you're going to get small cells, that's the microcytosis, and they're going to be hypochromic. That means they're not going to be as red when you look at them under the microscope. You're going to have normal hemoglobin, hematocrit, red cells, low ferritin, and your MCV and MCH start to drop. And then the last category, now you start to become anemic. So that's kind of the stages of iron deficiency. So who's at risk? So female athletes, why are they at risk more than others? Because they menstruate, so they lose blood through menstruation. And there may also be some increased incidence or prevalence of eating disorders. So nutritionally, they may not be optimized. And your endurance athletes, so males can become iron deficient too. Those who also avoid certain things. So if you're avoiding red meat, if you're eating a vegan diet, you may be a little bit more at risk for that. So you have to be very cautious with your, with what you're eating, and maybe supplement if you need to. And then those with malabsorption, so celiac disease, which is a true gluten disorder, it causes the cells in the intestine to really flatten out. All those nice villi that you have in your small intestine flatten out, and then you don't absorb a lot of nutrients. The other thing I wanted to talk about was vitamin D, because that's become extremely popular in not just athletes, but also non-athletes, the whole world. And so in medicine, I've had at least 30 years experience in practice after training. And I will tell you that in medicine, the pendulum likes to swing, right? So we find something and on a real kick with that, and we say, aha, this is it. This is the holy grail. And we need everybody that has this, we have to correct this. And we have to be aggressive about that. And then after we do that for a little while, what happens is people find out, maybe that wasn't a good idea to do that in everybody. And then the pendulum swings the other way, and it tends to go back and forth. And sometimes we get to the point where it falls in the middle. And I think this is kind of where we went. For a while, vitamin D was everything. And I think we've kind of backed off a little bit on that. So its deficiency is linked to bone health. It may also be linked to some of these other things. And there may be an association with iron deficiency too, whether or not that's just because of bad nutritional practices in that same individual. Sorry. The role in athletic performance, some have suggested that there may be improved muscle recovery after an acute bout of exercise, but this is still a little bit controversial, I think. These are the normal and insufficient and deficient values. So this has been set by the Institute of Medicine. And so you can see normal is basically 31. I forgot to put, it's about 31 to 150. So you get above 150 and now you're toxic. And in the United States, most labs are in nanograms per ml. The ones that are in nanomoles per liter are typically done in other countries outside the US. And so we don't really know yet, I think, what the ideal range is for an athlete. Is it more than the normal population? Right now, the paper that I cite in the references here just came out in 2018. And in athletes, they suggest just replacing beyond 30 nanograms per ml. So and then you have to monitor. You don't want to just blanketly put everybody on vitamin D, because that's going to prevent stress fractures. That has been done in certain institutions, but the feeling is we should back away from that and individualize it for each athlete. So does supplementation help athletes? And again, this is somewhat controversial. It may help with bone health and with musculoskeletal problems, and low levels may affect iron. So if they're not both corrected. So again, we should individualize based on labs, and also note that there may be some racial differences. So darker skinned persons may have lower levels of vitamin D, but actually utilize that vitamin D better because a lot of them have higher bone density. So you'd think, well, if I have a low level of vitamin D, that's going to adversely affect my bone density, and that's not the case. And we're finding out because genetically there may be differences in the vitamin D binding protein concentrations. And so again, that may be, it's the free vitamin D that may be more important than total 25-hydroxy vitamin D. So I want to touch just briefly on female athlete triad. That could be a whole talk. It's thought to be basically a relative energy deficiency, and there is a group that has proposed that maybe we should change female athlete triad to the name of relative energy deficiency, because males can also have this. This is a little bit controversial, and there's pros and cons to that. I think you just need to know what it is. So basically, it's menstrual irregularity, usually not having normal periods. So either true amenorrhea, which we said was 3 months in a row of no periods or more, or it could be maybe just longer than the normal cycle, which would be 35 days in between. Disordered eating, so it doesn't have to be full anorexia or bulimia and clinically make those diagnoses. It could be a combination. Maybe you don't clinically make the true diagnosis of anorexia, but you're not taking in enough calories to maintain, and maybe you've got some body dysmorphia so that the person doesn't see themselves the way the rest of us see them. They're thin, but they think they're overweight, and they have low bone mass. So that's kind of the definition of the female triad. And the idea is that may lead to stress fractures. So first you have to rule out other causes of amenorrhea and menstrual irregularity. The most common cause of amenorrhea is pregnancy. So, I mean, and that's something that oftentimes is forgotten to clinically evaluate for that, but that is part of the workup. And then you want to work up other things like thyroid disease, high prolactin levels. Those are commonly treatable causes of amenorrhea. So before you get to female athlete triad. And then the treatment oftentimes involves a multidisciplinary team. And so it's, with our psychologists or nutritionists, myself, and we're not the ones primarily treating these athletes. We try to find them resources in their community where they can get adequate help for this. So many times there's a lot of resistance on the part of the patient, though, to get help because they don't see it as a problem. The one thing I want you to take away, because I can't tell you how many times a year that I hear this, and our team hears this, one of our athletes with amenorrhea will go to a physician, even a gynecologist, and they will tell them that it's normal for an athlete to not have their period. It is not normal for a female athlete to not have their period, only if they're on hormonal treatment. But again, you may be covering up the female athlete triad with that. And estrogen replacement because these female athlete triad patients usually have low estrogen levels. So you can say, well, just give them the pill. And that's what we used to do. We found that improves bone density up to a certain point, but not as much as it would if you were to correct the relative energy deficiency and their nutrition was better. Poor sleep. I want to touch on this because this is huge. In our population, it is really, really huge. These athletes are going through multiple time zones. So you're taking an athlete who lives in Romania and they fly to Beijing and they play the next day. How do you think that works? Not well. Usually does not work well. I had one who flew from, I think, New York City to Beijing. This was two years ago. And decided to practice, hadn't eaten anything. Her strength and conditioning coach was with her. He was a new guy, poor guy. He didn't know what to do with her. She said, we're getting off the plane. She didn't sleep hardly at all on the plane. She hadn't eaten anything. She hadn't drank anything, and went right to the practice courts. And then she got lightheaded and dizzy. That's a surprise, right? So even though these are elite athletes, sometimes they don't always make the best decisions, and you have to kind of work through that and counsel them. This particular strength and conditioning coach, he was very concerned about her. He was trying to get her to do the right things, but the athlete was resistant. And so sometimes it is a partnership with your athletes. So think about the typical college student sleep schedule. I had two daughters. I still have two daughters. They went through college. I went through college. I know what the sleep schedule's like. It's not good, right? You like to stay up late, hopefully studying late, and you wake up late, right? That's not what the rest of the world typically does, not when they get out of college and start working. And so it may not be the best for recovery. And with our athletes, the last bullet point, they may have a late game. And so sometimes they finish at 2 a.m. Now, most of the time, the tournament directors are not going to put them on first match the next day when they're the last match on of the evening. But it doesn't always work out that way. And so their sleep schedules can be way off, and they don't have control over that. as somebody who has a 9 to 5 job, who can go to bed at 10 or 11 o'clock at night and wake up at a regular time, which is with good sleep hygiene. That's what we recommend, that you have a set bedtime and a set time to wake up, and you try to stick to that. That's good sleep hygiene, which is going to help most people recover. Jet lag is huge. I talked about, flying over multiple time zones and then trying to practice or play quickly after that. And so trying to counsel the athlete, if possible, try to get to your venue a couple days ahead of time. That's not always possible. As you think about the Jags, I don't know if our strength coach is still here, they don't have the greatest record when they fly to the West Coast, right? When they play West Coast teams out there, they just don't, that came out last year, they just don't have a good record against them. And so, that several hours difference can make a difference in how people perform. So when do you suspect overtraining syndrome? I think you have to make sure as a clinician and as a team, as a healthcare team, and you all are part of that team, that you have really ruled out the other underlying medical issues, and you've tried to correct those other underlying medical issues. Overtraining is something, and we see it on occasion in our athletes. It's not incredibly common. I think we get to them a little bit before they reach this, but occasionally they're resistant to recommendations, and then they go on to a true overtraining syndrome. But it's fatigue with decreased performance despite increase in training when other underlying causes we talked about have been ruled out, and shorter bouts of rest have failed to improve the symptoms. And shorter bouts could be days or weeks of rest, and the person is just not improving. And so most of the time, coaches and athletes are going to think, I got to work harder to get better because my performance is now starting to fall off. So what do? I work harder. And if that's failing to improve things, and then they're trying the rest and they have good recovery, then you really have to start thinking about overtraining syndrome. These are some of the parameters that have been related. So performance decrements, high fatigue ratings on the athlete's part, decreased maximal heart rate, changes in blood lactate threshold, and high reported self-stress levels. And these are some of the symptoms. So I put over here the emotional psychological symptoms here on the one side, so you can see depression. I mean, depression could easily be a piece of this, or maybe that's what they have, and that needs to be adequately treated. Emotional instability. So the person that wasn't ever snapping out at people, now they're snapping out at you as their strength coach. Irritability, restlessness, poor sleep. Again, a lot of those can be depressive symptoms too. Physical, loss of appetite, weight loss, increased resting heart rate, increased frequency of injuries, increased frequency of infections has been noted also. And we talked about, so she had four bouts of upper respiratory infections in the last 6 months. Could be bad luck, could be all that plane travel, you're exposed to a lot of different people running around during respiratory viral season. So there are some tools that can help to monitor this. We saw some of the physical tools that Tom talked about earlier in his presentation. These are sort of survey questionnaires that can be utilized. And the two in orange there are the MTDS is a little bit newer, and that's a 22 question survey versus the 77 questions. Think about trying to get somebody to fill that out, frequently. 77 questions is a lot of questions to fill out. The MTDS compared to the REST-Q adds a little bit more on mood and behavioral questions. The profile of mood states has been something that's around that's not just for athletes, but it has been used in athletes. And so these are just some questions. You can see the last one is the life events for college athletes. I looked at that one online. You can pull these up online and look at the questionnaires and see, if you think that that's going to help you for your athletes. There was a study that compared a couple of these to see if they were valid in athletes, and again, the two in orange there seem to come out pretty good. So what am I going to order? This is our fatigue profile for the WTA that we ask players to get so that they can, they can go to their doctor, they can go to a tournament physician, and these are the standard labs that we would want. So CBC is a complete blood count. That's going to give us our white count or red cell count or hemoglobin. Inflammatory markers such as a sedimentation rate and a C-reactive protein. Liver function studies, I want to rule out liver disease, electrolyte disturbance, BUN and creatinine, those are kidney function tests. This athlete's also been taking some ibuprofen. We want to make sure she doesn't have kidney disease as a result of that. Calcium, phosphorus, magnesium, we will get zinc. Our nutritionist who works at the Olympic Training Center out in Colorado Springs, they use a lot of AM cortisols. I haven't been overly impressed by that to do that on a case-by-case basis rather than monitor somebody over time, but we do get that. Total protein, albumin, ferritin, of course, the iron studies, B12, folic acid. Typically, we do ask them to get a vitamin D, and then a thyroid hormone, and monospot is for mononucleosis. It's a screen for mononucleosis. So if you have initial mono symptoms, most of the time it will be positive, but not always. So let's say those, for the most part, look pretty normal. Then we might go on to further laboratory testing, looking for rheumatologic disease or connective tissue disease. The anti-nuclear antibody test is kind of a screen for that. If that's positive, that requires further testing. And then creatine kinase, right, for muscle breakdown. A lot of our players will get that and they'll be minimally elevated. We're looking for things that are way off the charts. Epstein-Barr virus titer. So Epstein-Barr virus is the one that causes mono. So if our mono spot were negative, but I'm still suspicious, we might get a Epstein-Barr virus titer. And the same with CMV, cytomegalovirus. Looks like mononucleosis. I mean, it can create the same symptoms. And the same is true for HIV early on in the process. HIV, CMV, and mono all have very similar symptoms in the early stages. Hepatitis studies is something we might do. Lyme titers. We actually had an athlete who had Lyme meningitis. And then a serum protein electrophoresis looks at abnormal protein patterns within the blood that could be related to other serious bone marrow diseases or even certain bone marrow cancers. So let's look at our player, our made-up player. So she's got a normal hemoglobin, so she is not anemic. Under 12 would be abnormal for a female. So she's just over 12, so that's normal. She has normal iron studies, iron and TIBC, but her ferritin is low. So I said 15 was the cutoff, so she's 12. So she's iron deficient without anemia, right? She has normal chemistry, so your sodium, potassium, all those things. Everything else is normal. Her Epstein-Barr virus titers were negative. And her vitamin D is 25. I said that less than 30 is insufficient. And so we have tennis players, right? They're running around, they're playing outside in the sun. Why are they vitamin D deficient? Anybody have any ideas? Yeah. Malnutrition. Could not absorb. What else? Sunscreen. Yeah. So sunscreen reduces your skin's ability to convert vitamin D or produce vitamin D by 90%. So we have a dermatologist that comes and see all these girls. We've had several girls who have had skin cancer at 30 years of age because of all their sun exposure. And so he beats into their head, you got to wear sunscreen. You got to wear sunscreen, right? So it's a balance between those things. And so probably more important for them to wear sunscreen and supplement with vitamin D if they're deficient. So, and then inadequate recovery or breaks from competition. So this is my impression. So multifactorial fatigue. And I think this is key. A lot of times in medicine, we like to try to force everything into one particular diagnosis. Sometimes that doesn't always work, and fatigue is one of those. So I think there were multiple causes in this in this case, that we could tease out, and you want to try to correct them. You can take it very scientifically and say, okay, I have an elite athlete, I'm only going to correct her iron and see what happens over a couple months, because that's going to take 2 to 3 months to correct, unless you're going to give her IV iron. And so, but that's in an elite athlete, that's not probably the best approach. I think we need to try to correct as many of these things that are low-hanging fruit, that are easily correctable, rather than just say, okay, let's try one thing and see what happens in this case. So for her iron deficiency, without anemia, she's got vitamin D insufficiency. She has inadequate recovery or breaks from competition without an increase in training. She has likely female athlete triad. She's had a couple stress fractures. We don't know what her bone density is at this point. She was amenorrheic, and we're probably covering that up. And most likely we don't know, but she could have an eating disorder. And then she has poor, I didn't get into that, but we talked more about it. She does have some poor sleep hygiene, and there are some significant psychosocial factors that may be playing a role. So what do? We're going to restart her iron. I'm going to give her 65 milligrams of elemental iron daily, if possible, if she can tolerate twice daily. She may need a stool softener, because they're all going to complain of constipation. Not all, but several. Going to increase her calcium via diet and possibly with supplementation. Start vitamin D, usually about 2,000 units daily. Get a DEXA scan to assess her bone density and see where she is on the scale. Recheck her labs then in 3 months, because we want to monitor. We don't want to just start those things and then say, see you in a year. And never really get into more detail with the sports nutritionist, and then try to improve her diet and institute those dietary changes. Find out why she's restricting red meat, why she's restricting dairy products. And then meet with our athlete assistance team, which is the psychologist, the mental health care counselor, and work on stress management techniques. And then educate her about proper hygiene. And then our physios will follow up with her and then get back to us as they monitor her over the course of the year. And then on the WTA, the Athlete Assistance Program developed what's called the schedule zone. And so they can go on, it's a very nice computerized program. They can look at each tournament throughout the year, and they can design their schedule where they might take breaks. This athlete needs to take a break from the tournament, and not just take a break and then train really hard in those 2 weeks, but take a break to help with recovery, train some, and then get back to play again. And then you have to gauge their willingness to change, because sometimes people don't want to change, right? And maybe there's resistance on the part of the coach. Maybe there's just resistance on the part of the athlete or the family, and you have to kind of tease those things out. And then we talked about the recovery. So in conclusion, fatigue in an athlete can be very challenging. Oftentimes comes down to multiple factors as the cause. You want to identify those treatable causes, that low-hanging fruit that you can really make a difference with, and then try to institute those changes. If you've sufficiently evaluated the athlete and there's no obvious cause of fatigue, and their symptoms do not improve with some short-term rest, then you want to start thinking about, could this be overtraining syndrome? Athletes, coaches, sports medicine professionals need to ensure that proper recovery techniques are used for the athlete, and Dr. Kramer talked a little bit about that, and I think that's been a big push here in the last years, and I think we really need to explore what those are and figure out what are the most valuable recovery tools in the future. And obviously, as Dr. Fleck said, more research is needed. So thanks.